Good evening, everyone, on the East Coast, and it is still afternoon on the West Coast. I want to thank everyone for joining us tonight. My name is Andrea Baer, and I am with Mended Hearts, and we're excited tonight to present Seconds Still Count, Getting Emergency Care in the COVID Era. This is a part of our Stay in Care series, and we're very excited to have some great presenters with us this evening. For a couple of housekeeping notes, all attendees are in listen-only mode. So if you cannot hear, check the audio button on your personal computer to make sure the sound is on. That is usually the issue, and that will help, streamline the listening for you. Please type your questions into the question and answer box at any time during the broadcast. We are excited to get questions and answers, and we love to get them. The moderator will read your questions during the question and answer period, but you don't need to wait to type it in. And then finally, a PDF version of the slides, as well as the recording of this presentation, will be available on the Mended Hearts website following the event. It typically takes a day or two, but not too long. So I would like to introduce to you the speakers that we have tonight. Dr. Kirk Garrett from Christiana Care, Dr. Julie Ramos from Columbia Presbyterian Medical Center, and I am the moderator for tonight's panel, and I'm the executive director here at Mended Hearts. So without further ado, we're going to get right into it with a fun poll. So you're going to see a poll pop up on your screen, and it's going to ask you this question. How comfortable do you feel going to the hospital or doctor's office if you're experiencing heart attack or stroke symptoms? So the poll is up. You can feel free to vote how you feel right now, and then we will show the answers. I do love the answers so far. All right, so I think we're going to go ahead and end the poll, and I will share those results. All right. So I think, Dr. Garrett, Dr. Ramos, I think that we have a pretty good crowd tonight because they are pretty comfortable, a little nervous, but they would go. Nobody would say they would not go to the hospital. I think that's a good start. All right, so we're going to go ahead and get into the presentation, and I will turn it over now to Dr. Garrett.
Well, thank you, Andrea, and I agree with you. Those results are encouraging, but if I'm honest about it, they're not overwhelming to me. I was still reading a lot of concern, a lot of hesitancy. It's a wonderful thing that nobody said, I wouldn't go. Because if there's one message we want to leave you with this afternoon, it's that you should not delay care if you think you're having a serious medical problem. Now, we're cardiovascular folks, we're focused on those disorders and their lethal problems that are common. And if you have symptoms of stroke or heart attack, you really want to get that tended to. But you should also not delay if you're having a serious problem of any other type. If you think you have belly pain that won't go away or something is not working right on your body. What we have observed during the COVID pandemic is that people appear to be hesitant about coming to get care when they need it. And that can have really adverse consequences for folks. Those observations led the Society for Cardiovascular Angiography and Interventions, or SCAI, to launch a survey. We wanted to get a sense of exactly how people felt around this issue. This survey went out to about 1,200 Americans around the country. And we learned some pretty startling things. We found that half of the people we surveyed said that they were more afraid of contracting COVID-19 than they were of having a heart attack. Now, remember, Heart attacks are leading killers in America. Cardiovascular disease kills more Americans than all cancers combined. It's a lethal disorder. Sure, you can survive a heart attack, and most people do, but only if they get the right care in the moment. If you delay care, we miss the opportunity to pull you back from the brink and get you set right again. The survey also showed us that 40% of Americans view hospitals as a very, very dangerous place to go if you're worried about COVID-19. They saw going to a hospital as being riskier than going to a hair salon where people are going to be working very close to you and touching you around your head and face. More dangerous than going to crowded places like concerts or beaches. Okay, sometimes beaches are relatively lonely and you can walk along in the fresh air, and that's very safe. But if you've seen the pictures of the beach communities this summer in areas where folks have been allowed to go back, I think you can appreciate that there's danger there, real danger. And for people to think that hospitals are more dangerous than those places is really alarming. Furthermore, the majority of people worry about contracting COVID-19 so much that they said that it would stop them. That anxiety, that concern would stop them from going to the hospital during a medical emergency. This is really, really an anxiety-provoking issue for cardiovascular practitioners like Dr. Ramos and myself, because we know that if we can get people to come into hospital, we can care for them and keep them well. I think a really important message here is that hospitals are places that are used to handling infectious diseases. This is not the first contagion we've faced. It's a unique one. It's a very dangerous one, but we've faced unique and dangerous infectious diseases many times in the past. And in fact, on a daily basis, hospitals are focused, often hyper-focused, on maintaining standards of cleanliness, sterility, disinfection, to assure that people don't acquire infections in hospitals. It's much safer to go to a hospital than to go to, say, a grocery store if you're worried about the standards of cleanliness. Let's go to the next slide. I think most people on this call are familiar with the symptoms of heart attack and stroke, but just to make sure that no one forgets that there are classic signs of stroke and heart attack, and then there are the less classic signs of stroke and heart attack. At the bottom of this page, this fact sheet on heart attack and stroke symptoms, the Seconds Still Count campaign has summarized for you those classic signs of heart attack and stroke. Most people know that a classic heart attack is a crushing pain in the chest, often extending into the arm, usually the left arm. It can go up into the neck or the jaw. Often breathing is difficult. Your heart may be pounding. You may feel sick on your stomach. You may sweat or feel lightheaded. Those are classic symptoms. For strokes, often it's a feeling of numbness or weakness in some body part, typically an arm or a leg, but also there could be drooping of one side of your face or the other. Vision may be a problem. There may be areas of blindness, or maybe areas where your vision is just completely, your sight is not available to you. It's not as if you see a dark spot. You just don't see in an area. It's as if you're trying to look out the back of your head. There may be troubles with balance and dizziness, as you might imagine, confusion, and then commonly people have difficulty speaking. Now, occasionally people have a stroke and they're less aware of their own symptoms than the people around them. So if someone says, gee, are you okay? I'm not understanding what you're saying and your face looks a little funny, that's something that you should pay attention to. Pain in the head is also often a feature in severe strokes. Now, while those are the classic symptoms, I need to emphasize that not everybody has classic symptoms. With heart attacks, we all know that some people don't have any of those things on that list. They'll just feel funny. They'll feel a vague sense of being unwell. Often people can say, I can't even put it into words. I just know something is wrong. Sadly, women are much more likely to have those less typical features. It can make the diagnosis in women more difficult. The same is true of diabetics of both genders. With strokes, sometimes people will have relatively mild strokes so that dominant features on this list aren't as apparent. Or they may have the so-called mini strokes, the little transient ischemic attacks, TIAs. You have an event, but it doesn't stick. It breaks free on its own. The blocked artery breaks free on its own, and the symptoms go away. Those are still really, really dangerous things, and they require urgent medical care to keep you safe. If you have any of these signs or symptoms, or if you're concerned that you may be having a heart attack or a stroke, it's essential that you go to hospital promptly. Don't try to tough it out. Don't try to wait it out. Get help. We can go to the next slide.
Thanks. Thank you, Dr. Garrett. Hi, this is Dr. Julie Ramos. I'm going to be speaking about symptoms with some gender differences. And I think it's very important that we emphasize that women do develop chest pain. I have seen plenty of women with chest pain, even young women, but there are many times I've seen in my practice where they present not with the typical substernal chest symptoms, but more of these vague symptoms. And some of these may be just generalized weakness, body aches, and you know, anybody who gets older has body aches, if you ask me. So, you know, a lot of these symptoms may be dismissed. In addition, things like shortness of breath. I have a lot of ladies who complain about not being able to go up the stairs as easily because they get winded. A lot of the women that we've seen in the emergency room have had even GI upset, nausea, vomiting. They always, at least in our emergency room, obtain troponin. So these, even though it's below your belly button, maybe you have some indigestion, we are very aware that women can present with atypical symptoms. Other symptoms are fatigue, tiredness, discomfort in your back, arm. At one point, I had a woman who presented to me who said, you know, every time I walk, I get pain on my left wrist. And that was her presenting sort of chest pain equivalent. And, you know, as you get to know and speak to the patients, which, you know, I learned in medical school, 80% of the diagnosis is history from the patient. It's not the test, it's not anything. It's listening to the patients and really having that time to listen to them. And another one, which is very interesting, is difficulty sleeping, whether you're having that aching or shortness of breath. A lot of these women, we kind of have to be in tune. And as a woman, you should not be shy about discussing these symptoms with your doctor. You know, nothing is too little or to be belittled or too minor to really complain to your doctor, especially if they're new symptoms. You know, and I want to also bring into perspective, you know, the goal of today. I'm a cardiologist. I work in New York City. I have been the epicenter of this pandemic. And I think that the effort that Mended Hearts and SCAI is doing is of utmost importance. You know, before the pandemic, my practice was full of patients, very sick, you know, and 30-year-olds, 40-year-olds. These are not just older patients. And it's important that we have to keep in mind, we have done so many changes, not only in our physical areas where our patients either sit in the waiting room or schedule. We've also elongated the schedule boxes. So not only no longer are patients being scheduled every 15 minutes, we're staggering them, you know, every half hour, every hour. So there's not congestion in those waiting rooms. This is a very sensitive topic. We measure the chairs. We've blocked off chairs. We've moved chairs around to ensure that our patients are sitting 6 feet apart. And obviously we're taking temperatures, and even before our patients walk into the office, our receptionist is actually screening. She's asking Have you had a temperature? Have you had a positive test? Have you had a close contact who's been sick? Have you had shortness of breath or a cough? Anything related to COVID? So all these implementations have taken place, and we've learned through this pandemic, and we've learned to really try to screen our patients. So what did I do during this pandemic? I believe the power of telemedicine is a huge benefit to the community. I think as a physician, we're actually able to reach more patients in a more timely manner with these tools. But I have to say, it doesn't replace you coming in for your annual testing, such as your EKG or your echo, or coming in to, get your blood pressure checked. Although now my patients have all routinely obtained their own blood pressure machines. So they're already ready before I call them with their readings. And that is very important. And I believe that engaging my patients during this pandemic has been even more beneficial. So now they feel like, oh, I'm going to check my blood pressure, and they're more involved. It's not a technician taking their blood pressure. So I think that is a very significant change that I have seen. And also, I think there's more frequent contact with our patients, given that telemedicine gives us that possibility. As well, I work at a medical center, and our hospitals, which are a major medical center where, obviously a lot of our wards were converted into COVID wards. There were many patients who had to be accommodated during this pandemic with, my patients themselves, strokes, heart attacks, etc. And, through this pandemic, things were changed. Certainly people's roles were changed, but routinely now hospitals are, at least where I work, are pre-screening patients. So with questions, with nasal swabs are done pre-visit, especially if you're going to go to the cath lab, especially if you're going to get something like a pulmonary function test, etc. Social distancing is definitely observed, and a limit number of visitors. I mean, really, we just want you as a patient there if absolutely necessary. And obviously, masks are being required. Next slide. So as we had been speaking, I can speak for, my experience working in, the epicenter of New York City. Again, many of my patients have had acute GI bleeds, strokes, or heart attacks. They've been accommodated. I've surveyed them myself, and I said, do you think they have taken precautions? And they said extreme precautions. Everyone was very careful. If medications were to be administered, a lot of them used a small window or something to administer it. So, we have learned to adapt. I think it's certainly been easier in the doctor's offices to adapt. And obviously hospitals are equipped right now to really deal with any emergency, plus, isolate the COVID patients versus the non-COVID. Next slide.
Well, I think it's probably a good moment, Julie, to remind everybody that there's a lot you can do actively to help reduce your risk of cardiovascular disease, whether during a COVID-19 pandemic or otherwise. These should be, for the most part, familiar recommendations to everybody. We remind people to take their medications and to take them on time, not because it's easy. It's actually much harder to do than you would ever imagine. But in fact, it turns out to be very, very important. I think it's worth noting that the medications that we have today have proven themselves to be enormously powerful at preventing heart attacks and even deaths as a result of cardiovascular disease. When our parents or grandparents had heart attacks, say back in the 50s, 60s, even into the 70s, their chances of surviving were not that great. Someone going into the hospital in, say, 1965 could have a risk of dying of that heart attack as high as 40%. But with the new care algorithms in hospitals and with ongoing medical care that's advanced enormously over the last half century, your chance of dying of a heart attack, if you're unlucky enough to have it, is about 1/10 of that. Medications are really the mainstay of treatment, and staying on your regular schedule, not missing your pills, is really annoying and really important. Everybody has heard about the importance of staying active. You know, we're animals. We're fundamentally built to be active. We're meant to be chasing down our dinners at night, but we have evolved into a much more sedentary being. And when you sit still for too long, it messes with your metabolism, your management of sugars and fats and lipids and cholesterol and all those things don't work right. And that injures the blood vessels in your body in a way that can precipitate heart attacks and strokes. There is something truly magic about activity, and you don't have to be training for a marathon to get benefits out of exercise. Just taking steps. You've all heard about the 10,000 steps and how valuable that is. I'll let you in on a secret. It doesn't have to be 10,000 steps. You can get benefits even at lower levels of activity. If you're limited, arthritis, joint troubles, other health issues hold you back, it's okay. You can still do a big favor for your heart and blood vascular system just by continuing to be as active as you're able. I don't know what there is further to be said about a heart healthy diet. Hopefully by now nobody's mystified by the idea that we are what we eat. If you spend a lot of time eating cheeseburgers and Twinkies, you will pay a penalty for it, not just in heart attacks and strokes and the risk of blood vascular problems, but a whole host of ailments. Heart healthy diets are A, healthy, B, they really work, and C, they're fantastic. Most people, or many people at least, who haven't embraced a heart healthy diet are a little reluctant about it because it's just so strange and foreign to them if they haven't had a habit of eating well. But, my experience has been when I'm able to get patients to make a change and embrace a heart healthier diet, they really enjoy it. They like it a lot. It doesn't take long at all. And this is, again, another place where you don't have to be a Calvinist about this. You don't have to kind of exist on nothing but carrots and apples for the rest of your life. You're allowed a cheeseburger now and again. You're allowed that slice of pie. You just should be thoughtful about it. And remember, those are treats. Those are things that you reward yourself with occasionally. They shouldn't be the everyday fare. The other point to be made here is that as you start to think about how you're going to stay connected to your healthcare providers, realize you have more options now. One silver lining in the cloud of the COVID-19 pandemic is that the presence of this germ in our community has been a catalyst to the development and expansion of so-called telehealth opportunities for people. We've always done a certain amount of telehealth. You may have actually received a phone call at some time or another from a doctor's office about a scheduled appointment or a test result, or maybe managing your Coumadin. Those are forms of telehealth. But of course, we're ready now technologically to take it to an all new level. We have the ability now to interact, doctors have the ability to interact with their patients over a television screen or a computer screen, and get enough information and exchange enough information that experience can be a substitute for a live visit. And we believe that we can do this safely and effectively for people without significantly compromising their care. Certainly for people who have an established relationship with a doctor or another care provider, you're known to them, they know you. That's a perfect platform for exploiting this telehealth opportunity. It saves you the hassle of getting in your car and finding a place to park and going in to see the doctor or the nurse or the physician assistant. But it also gives you one less exposure to whatever may be circulating in the community. Again, I contend that doctors' offices, like hospital settings, are among the safest public places you can go. They're not dangerous. If you go to a doctor's office, you'll see all the usual things happening there that you see in the marketplace and other public establishments with social distancing requirements and face mask requirements and frequent cleaning of high contact areas. But remember, doctors' offices have been caring for people for a long time. They understand the risk of a contagion coming into the office, and they have care plans set up to manage things so that people are kept safe. Next slide.
Great. Thank you. So before we take this poll, I had a couple of questions that were submitted prior to this webinar, and I think it would be good if we could talk about it now, because I think some of those kind of feed into this fear of going to the doctor. The first one is around being limited on visitors and having people with you. I have had a lot of people say that they are concerned and fearful, actually, of going to the hospital and maybe being admitted and being alone. Can you maybe share how you have handled that on the front lines, and how maybe to put that fear a little bit more at ease?
Julie, you want to take that?
I can speak on that. So at the height of pandemic, where numbers were out of control in New York City, it just was better for the general population to not have visitors. Even women who were giving birth were not allowed their partners or husbands to be present during the birth of a child. In addition, vulnerable populations, which suffered a tremendous amount of loss in New York City and New Jersey, were nursing homes. And as you can imagine, the visitors there really, really had to be limited, although, vendors and things like that came in. Right now, there is a limited visitor policy. I think each region is going to react differently depending on their COVID positivity rate and their rate of, in current and ongoing infection. I think that I'll tell you, the nurses and the doctors have done such a tremendous job of just even communicating patients through their iPhones, the patients' iPhones. And again, talking about telehealth, I don't think that this is unprecedented, to be honest. I feel that if warranted, unless you really need to be in the hospital, I would definitely limit the visitors. But right now, they are limiting one visitor per, a certain hour period, but very limited. And I have to say that a lot of my patients were speaking about even going to their loved ones' funerals, and they were limited. So I think, limiting visitors at this time is appropriate. Certain vulnerable populations, such as nursing homes, we don't want to expose people to. So I don't think that the fear of being alone should be there. I mean, you're going to be cared for same as before. And thankfully, the rules have relaxed a little bit, but unless absolutely necessary, you really don't want to increase any community spread. But again, visitors in the hospital are strictly screened. They are gowned. I mean, they're not just face masks, they're gowned, they're gloved, face coverings. And then before you leave, they take it off. So it's a very strict protocol that's been implemented.
Great. And then the final question before we do our poll and move on to the questions from the audience, which there's already a few, I would like to ask for one of you to speak on the topic of wearing masks. It's a hot topic, but we have some people who are concerned about wearing a mask due to dropping oxygen levels or any of these things that might be floating around, can we just hear from an expert on why we should be wearing masks and if they are safe?
Sure, I'll be happy to respond to that. The confusion among Americans is understandable because there were mixed messages that came out about masks early in the pandemic. I think it's important to recognize that that confusion was not born out of any uncertainty about what masks had to offer overall for respiratory contagions like this virus. But the early recommendation to avoid masks was a reflection of two things. Number one, we didn't know how effective masks might be for this particular germ. We know some viruses are more easily controlled than others with masks. And secondly, early on in the pandemic, we were caught by surprise and we didn't have a very good supply of at least the surgical type masks that are needed in hospital settings to take care of patients. And there was a concern that people would rush out and buy them and keep them in their homes when they were desperately needed in hospital settings to take care of sick people. Today, we've learned a lot. We know that very simple masks of the type that you can make at home on, with just a bit of cloth can be very, very helpful in preventing spread of germs. Now, an important principle to remember is that when you wear a mask, the mask is not doing a lot to protect you from other germs that are in the area. Only very special types of masks, like the famous N95 mask, are able to do that. Those are highly specialized masks. They only work if you wear them in a specific way. They have to be fitted to your face. And by and large, they're neither necessary nor really appropriate for home use. On the other hand, a simple mask that you can make at home or you can buy over the internet is very effective at preventing you from sharing your germs with people around you. Well, the only way this really works then is if everybody agrees to wear a mask. That way we stop the spray of little droplets, which is how this virus gets spread around. And that's really important if you're in an enclosed area, in a school, in a cafeteria, restaurants, so forth. Particularly important in places where you can't respect the social distancing requirements. And remember, the social distancing requirement of 6 feet or more is really a recognition of the fact that when you speak, or particularly when you cough or sneeze, you produce little droplets that will travel. And happily, they don't travel so far most of the time. They'll drop out of the air after 6 feet or so. But you can contain that spray by wearing a mask and keep the people around you safe. I think of the mask, wearing a mask, as being a sign of respect to the people around you. And there are no common masks that you might buy on the internet or in a store locally, or that you would be likely to make at home, particularly if you use the guidelines published by CDC, that will in any way be a safety hazard to you. They don't limit your ability to breathe in and out. They don't reduce your oxygen levels. They won't create a more dangerous environment for you. There are a few very specialized medical conditions for which masks are not recommended, but they're quite rare. And if you have a concern that you may suffer with one of those ailments, I would recommend that you discuss that with your usual care provider and get their advice. They'll know how to advise you best.
Thank you. Thank you for that clarification and the great information on mask wearing. So I am going to launch the poll. It's the same poll that we had in the beginning, except after you've heard about what is happening at the hospitals, let me know how you feel now. And I have to laugh because there's a little tiny error in this poll and it says pool 2. So maybe we're going to go swimming later. I don't know. but choose which you feel now and how comfortable you feel now at going to the doctor. And then we will get right into the questions. I already have a few. If you have any questions that you would like to ask the doctors, please type them into the chat box or into the question and answer box. We have 2 of them, so we can work through both of them. I have the questions already that we can go with, and type yours in and it can be in line. Okay, just another second. If you haven't voted, feel free to vote. I'd like to know how you feel. You know, telemedicine, I have had a bunch of telemedicine visits for my children, my son, actually both of my sons, and it's worked out very well. I've loved having the ability to see the doctor and talk to the doctor, but not have to get in the car and drive there. And so that has worked well. But there have been also other times that we have gone to the heart clinic, and we actually had to go to the emergency room once, which was not fun, but we did it, and I felt very safe myself going, and felt that their procedures in place were very good. So, okay, I'm going to end the poll, and we can share those results. So we're still right around the same. Julie, would you like to talk about that?
Well, I can only tell you that I don't blame anyone for, you know, having hesitation, but to prepare, and I think it's very important that you sort of prepare before you know, go to your next doctor visit. Feel free to ask them, what sort of you know, safety protocols are you taking, are you doing? You know, if you were needing to go to the hospital, I think the fear of, I'll tell you, nobody in the emergency room wants to spread COVID or have COVID spread to somebody else. So there is very strict protocols, and I would start asking questions, because that's what I do with my patients. I want to know if they went to the emergency room, how social distancing took place, how was it safe? And we're in a major city, and none of them have ever said during the pandemic or after that they weren't social distancing, that didn't take very strict precautions to not spread it. I can only talk from my experience. None of my patients have been exposed to COVID from, you know, their surgeries that they had recently or anything of that nature. So these educational sessions are of utmost importance, and I think doing more of these is very important as well.
Great, thank you so much. So we are going to just jump right into some questions. We've got some great ones on queue. The first one is, can you speak to the silent heart attack, a heart attack in the patient when they feel no symptoms?
Sure, I'll take that one. Yes, this can happen. Unfortunately, it makes management of the acute event very difficult for everyone. Doctors hate this probably more than patients do, because it ties the doctor's hands and his or her ability to make a positive, have a positive impact on that episode. Yeah, but it does happen. Happily, most silent heart attacks are small ones, the sort of thing that you may go for a regular physical examination, and the doctor looks at your electrocardiogram and says, gee, it looks like you had a heart attack. I said, yeah, I don't know about any heart attack. Well, clearly, if that heart attack was going to have very substantial consequences for you, you would have known about it. The real danger there, though, is that a small silent heart attack is nonetheless an indication that you're at risk of future cardiovascular events. And, you know, the next one might not be so small. So if you do have a problem of that type identified, make sure you work closely with your care providers to organize a care plan to keep you safe.
Great. So how common is it for a heart attack to be confused with severe indigestion, such as gas, heartburn, acidity, reflux?
I can talk about that, especially atypical presentation of women. You know, I think that it's not uncommon, but as we have learned, you know, that is not an atypical presentation. I would say that maybe 10% of the patients presenting with GI symptoms, that's why routinely troponins are usually taken. And sometimes cardiologists go crazy because, you know, we say, oh my gosh, too many troponins are being picked up. But I think, you know, to be honest, and, you know, we get these silly consults and the troponins are extra sensitive. It means nothing. But you know what? I'd rather have extra troponins running around and really being careful and having a cardiologist lay hands on the patient than, you know, not running that troponin and missing a heart attack because, you know, plenty of people have succumbed to no symptoms and have died from, you know, not even having symptoms. So I think that and it's probably more common than we know because we haven't really tested the population. But again, we're a lot more sensitive these days. I want to speak about GI symptoms. We haven't spoken about COVID and some of the cardiac symptoms that it produces. So COVID in of itself causes heart disease, and I've seen plenty of it. And so we must not dismiss, you know, these pain symptoms as just something else, because COVID does also attack your heart muscle in different ways.
Wow. Okay, that's interesting. So the next question is a little off topic of heart attack, but somebody is asking what new advancements have been made in controlling AFib. And I don't know if you can answer that or not. If not, we can just say we don't have any answers.
Well, I guess I could respond this way. If you're looking for something that's come out new this week, I don't have anything for you. But if you look at what's happened in atrial fibrillation management over, say, the past 10 or 15 years, it's a brave new world. We have new medications that are highly effective. Unfortunately, some people, and frankly, ultimately most people, if they have AFib for a long time, will break through the medicines, and the medications alone won't be enough. Oh golly, I guess it must be 25 years ago, some electrophysiology people, these are folks with a specialty in heart rhythm disorders, started to really work hard on these techniques that we refer to as ablation procedures. An ablation procedure to the patient looks something like a heart cath that you would get for coronary artery trouble. But the actual things that are happening inside your body are very different. The electrophysiology doctors are using mostly electrical tools to chart out how the electric signal travels through the heart. And once they've got that mapped out, they can create little areas of electrical injury in the heart muscle. Now, you say, gee, wait a minute, we're talking about avoiding heart attacks to not have heart injury. Yes, that's true. But little tiny strategically placed areas of injury can alter the electrical behavior in your heart in such a way that it makes it difficult, sometimes impossible, for your heart to sustain atrial fibrillation. We do a lot of atrial fibrillation ablation work today, which really was using techniques that were basically non-existent 10 years ago or even less. Beyond that, we've also developed tools to help protect people, not so much from atrial fibrillation, but from the most dreaded complications of atrial fibrillation. Those are the complications that come about as a result of blood clot formation inside the heart, which sometimes happens in people with atrial fibrillation. There's a particular part of the heart where those dangerous blood clots most commonly form. And we've now got tools that we can use in the catheterization laboratory to seal off that part of the heart and prevent any blood clot that forms in that part of the heart from ever escaping into the circulation. Those escaped blood clots, as you know, can cause strokes. We hear about that commonly, but they cause all kinds of trouble. They can cause heart attacks. They can cause kidney injury. They can cause your leg to go cold. So these have been really big advances. And then finally, there are newer medications to be used for blood thinning, which is also helpful in preventing these complications of atrial fibrillation. And the newer blood thinning pills compared to Coumadin or warfarin, the old-fashioned pill, tend to be safer. They tend to be linked to fewer bleeding complications, which is really a problem with Coumadin.
Great. Thank you so much. So we have a couple of more questions. The next one is asking if you could comment about alcohol consumption after heart attack or stroke. Is 0 what it is, or is it okay in moderation?
I can talk about that. Obviously, these are things that come up after patients get out of the hospital, come to visit us. That plus, not only what should I eat, can I drink, can I have intimate relations with my partner, those things. And that is a very common topic that we deal with in the office. And I certainly think that is a fair discussion with your physician. And I have to say that it is an individual decision. I think that, alcohol in of itself is not going to cause heart disease, except in excessive amounts, but there are interactions with certain medications. So as we were talking about blood thinners, alcohol itself can thin your blood, and, in combination with other medications, it's not exactly, ideal. So it is a discussion that you should have with your physician. I can tell you from my experience with my patients, as long as I don't see that they have some sort of alcohol disorder and they're excessively drinking, I certainly let them have their social drinks, whether it's a holiday or a gathering, unless there's interaction with your medications.
Great. So how closely is major mental stress linked to the risk of having a heart attack? Is there data to support that
Yes.
that it's a valid risk factor?
Yes, there are very clear data about this, and we've learned a lot about this area as well over the past couple of decades. We know now, for example, that when you experience stress, and particularly when you're experiencing chronic stress, it changes certain chemistries in your brain. Now, your brain is connected obviously to your entire body, but one very important function your brain has is to control some of the hormonal balances in your body. We now know that chronic stress particularly causes a part of the brain called the pituitary to stimulate certain glands in your body to make certain substances. These include epinephrine or adrenaline, and also include a compound called cortisol. You might have heard of these things. Now, used in certain ways, these substances are very important and can be beneficial, but chronic overproduction of these things causes harm. Cortisol can lead to derangements in the way your body handles things like lipids and sugars. We know that increases propensity for becoming overweight, propensity for diabetes trouble, and we believe that this is an important contributor to plaque formation in arteries. Things like adrenaline or epinephrine, when chronically produced in high levels, affect your blood pressure. And we know that high blood pressure over an extended period of time causes injury to the arteries and also promotes the development of plaque. So yes, there's not just very good what we call epidemiologic evidence, that is looking at how people do and just saying, golly, people with a lot of stress, they have more heart attacks and strokes. We have evidence that that is true, but we also now have this explanation, a biological mechanism understood about why stress would cause this kind of harm.
Great. So someone is asking, and it's a little detailed, so maybe you can't answer, but it says, I had a 6-way bypass. Is it possible to do more, or am I set now for only stents? So I guess maybe the question is, can you have too many bypasses? Is there a limit on how many bypasses you can have?
Julie, did
Dr.
you?
Garrett? No, you can go ahead.
Okay, all right. So I don't know that you can have too many bypasses. Let me start there. It is true that if you've had one bypass operation, particularly an extensive surgery as described, then having subsequent heart surgeries can be challenging. They're difficult procedures. It's a very invasive thing. And sometimes we try to avoid them and go to great lengths to offer other therapies. But just because you've had 6 bypasses does not mean that you would not be a candidate for excellent medical therapy. And it's important to remember that medications is really where you get the greatest payback. This is coming from an interventional cardiologist, folks. I'm a person who's spent 30 years in a catheterization laboratory putting stents in people, and I have complete confidence in their value. But I recognize that they're just one part of the plan to take care of people. And the real payback is in taking your medications consistently and on a timely basis and in accordance with the directions from your physician. So you will always have that available to you. And if they're not enough and another surgery isn't a good option, often stents can be real game changers. They can be life-saving in certain settings, and they can certainly enhance the quality of life.
Thank you. So the last 2 questions. One is sudden cardiac death hereditary?
So I actually have had several patients, and I obviously speak about my own experiences and data behind them, where, you know, I always screen my patients for heart disease, and it not just coronary artery disease, but familial trends, especially with young people. You know, some young people come and say, I'm dizzy, I'm lightheaded, I passed out. And so that's when and even in middle age, you start drilling down of, tell me about, you know, any cousins ever, you know, not wake up, or, you know, some children, you know, drop dead, or anything of that nature. I ask because there are certain hereditary disorders, and we can probably group them into roughly 2 groups. One is a muscle disorder, where the muscle of the heart is not arranged in a perfect uniform way, which a normal heart is. And people are born that way. And sometimes they are found later in life, whether in their 30s, 40s, 50s, to have such a disorder. And you may have heard of hypertrophic cardiomyopathy, which is a disarrangement of the heart muscle. So their communication is erratic and can cause an irregular rhythm and sometimes fatal, causing death. The other is there are normal muscle arrangement, but the communication or the channels where the muscles communicate with each other have certain ions, sodium, potassium, going in between and channeling between these muscles. And as they communicate with each other, some of these channels, some people are born with what we call channelopathies. And those are also inherited disorders where a genetic lab would be involved. And there are several patients I have sent for testing because they do have a history of such. And usually those are at major medical centers to have a channelopathy.
Great, thank you. And the final question is, what's the difference between a heart attack versus cardiac arrest? Is it the same thing?
Julie, do you want to take that?
Sure. So it kind of goes along. So Again, sometimes we use it interchangeably, and I think we're maybe a little guilty of it at times when we speak to a patient. So a person who has a heart attack, basically what we're specifically referring to is there was some sort of occlusion of a blood vessel, part of the muscle is injured or died, and the person doesn't necessarily have to meet a fatal event or anything. It could be a small heart attack and you show up in the emergency room and it just shows up on your blood, or it can show up in your EKG, or it can go into something like a cardiac arrest. Now, cardiac arrest can fit two categories. So a cardiac arrest is when your heart basically stops. Sudden cardiac death, your heart stops. What is the cause? So we can do the two buckets again. A lot of times it could be due to that clogged artery that caused a heart attack. It was large enough where your heart muscle was irritated and it stopped pumping for whatever reason. Whether it's mechanical or electrical. And the second bucket is electrical. So a lot of patients develop weakened heart muscles or cardiomyopathies. And in these cardiomyopathies, patients' electrical system are deranged for one reason or another. And this derangement causes either ventricular tachycardias or ventricular fibrillations, which is an erratic beating of the bottom of your heart, and it causes sudden cardiac death. So again, heart attack in of itself, when we're speaking about it, it's usually heart muscles injured from some sort of coronary blood flow obstruction. And sudden cardiac death can be caused by a heart attack, but it also means that the patient, some sort of way the heart stopped, and it could have been due to an electrical problem or some sort of a heart attack.
Great. Thank you guys so much. We really appreciate that. Before I let everyone go, I just wanted to take a moment and thank you both for joining us. We really appreciate the hour that you've spent. And I would also like to thank SCAI, which is the Society for Cardiovascular Angiography and Intervention, for helping put this webinar together to educate all of our patients and family members. There is the handout that was referenced in the slides earlier in the presentation. SCAI has graciously sent that over to us, and we will place it on the website with the link to the recording along with the slides. So look for that on the website in just a couple of days. It will be under the Stay in Care button on the home page. It's a big blue picture on the left-hand side. If you click there, you'll be able to get the recording and the handout from that. I hope that you all stay safe, and we appreciate you joining us this evening. Dr. Garrett, Dr. Ramos, thank you again, and we appreciate it.
It's been a real pleasure. Thank you.
Thank you. Everyone, have a great night.